Hello everyone, welcome back to pediatric teaching, postgraduate teaching that is. And today we are going to talk about a common topic. Again, psychiatry I'm going to choose first. And the topic is ADHD. Okay, pediatric psychiatry, child psychiatry. All right. Now I'll be covering this in sections, and the source of this material is DSM-5 textbook of child psychiatry. Okay, and by American Psychiatry Association. So need not worry about the information, it's quite latest and quite reliable. All right, but the thing is, it's any psychiatry topic we cannot approach like a normal other pediatric topic relating to disease or anything, because the approach to a psychiatric topic will be different. So let's go a little, interestingly, you can say. First we'll go for some history, you can say, or some introduction. Okay, let's say introduction. In introduction, what I want to mention some interesting points is, historically, before this syndrome of hyperactivity, impulsivity and inattention was named as minimal brain damage or minimal brain dysfunction also. Okay, minimal brain damage or minimal brain dysfunction. Some called it even hyperkinetic syndrome, some called it ADD, attention deficit disorder. All right, but now this term, which is ADD, is no more accepted. Okay, although it is used in like media, social media, and in films and magazines and novels, all other things, they may use this term, but it is no longer correct. Now DSM-5 has made the term as ADHD. Okay, that is attention deficit hyperactivity disorder, which has primarily involving the triad of hyperactivity, impulsivity and inattention. Okay, and previously there were DSM-4 had subtypes. Okay, the subtypes have been now replaced by similar presentations. Okay, in DSM-5, that is combined, which is meeting the criteria for both inattention and hyperactivity impulsivity, or predominantly inattentive or predominantly hyperactive impulsive. Okay, this is what you need to know about some introduction. Now next, coming to actually it's a very what can I say, there's a lengthy criteria also for this, but for pediatric point of view I will just simplify the criteria so that you will know just the basics. Okay, so DSM-5 criteria for diagnosis of ADHD, there are 5 parts to this criteria: A, B, C, D and E. Okay, now A says there should be a persistent pattern. A persistent pattern of what? Inattention and or hyperactivity impulsivity, that is interfering with the patient's functioning and development, normal development it is affecting. So there's a persistent pattern. All right, that is the main keyword here. It's a persistent pattern of inattention and or hyperactivity impulsivity that is interfering with the function and development of the child. Okay, second, several inattentive or hyperactive several inattentive or hyperactive impulsive symptoms were present which are prior to the age of 12 years. So that is the keyword, prior to age of 12 years. Several hyperactive impulsive symptoms or inattentive symptoms are present before the age of 12 years. Okay, then several inattentive or hyperactive impulsive symptoms are present in 2 or more settings. So greater than equal to 2 settings there should be symptoms of what? Inactivity, hyperimpulsivity and hyperactive impulsivity. All right, there is done. Then fourth part is, there is clear evidence that symptoms are interfering or reduce the quantity of social, academic and occupational function. So what? Affecting 3 domains: social, academic and occupational. Okay, occupational function is affected. Okay, there should be clear evidence for that. Then symptoms, last one, symptoms do not exclusively occur during the course of schizophrenia or another psychotic disorder. That is, it is not explained by any other mental disorder. Okay, mental health disorder. Alright. So basically the keyword would be not explained by any other psychotic or neurotic disorder. Okay, so this is little about the criteria. So you have 5 criteria. It should meet all these criteria so that you can label the child as ADHD. All right. Now what you need to know little about the core components of ADHD is, the core deficits in ADHD include, it's an impairment relative to the expected developmental level. Okay, it's an impairment which is relative to the expected developmental level. Okay, and the impairment is mostly in learning and in following rules. Okay, and there's difficulty in inhibiting impulsive responses to internal wishes. Okay, so all these things may be present in a child of ADHD. Okay, and ADHD children have high levels of motor activity. Okay, in variety of settings there will be high levels of motor activity. Okay, and what you need to know is, in the classroom, however, restlessness, fidgeting, walking or running around without permission will be present, and that may be when we detect the child. See, if in a playground a child is hyperactive, nobody is going to pick up that child, right? Because it's normal. Child with ADHD, without ADHD, both will be kind of hyperactive in a child playground or while playing or some exciting activity is going on. So in that setting, you may not really pick up a child who's ADHD. But if you want to pick up a child, very good situation would be somewhere where there is organization involved and sitting for a long period of time. All right. So this is restlessness, fidgeting, walking or running around without permission during the classroom is going to cause problems. Okay. And what other things you may see on entering a room, a new room, suddenly you may see the child is beginning to touch and climb some objects, trying to grab something. Okay, so something like that. All right. And what you need to know is, the main problem is these ADHD children are wanting immediate gratification. Okay, like they want immediate results, like they want something, they want to do it, and they cannot stop their thought, they cannot inhibit themselves, their response. All right, so this is what is a little about ADHD. What you need to know is this one thing which I've all told is can be summarized in something called as OTMP. So what is the problem in ADHD? OTMP, there is a problem in organization, time management and planning. Okay, organization, time management and planning. Okay, so deficits involve OTMP. Okay, in ADHD, that you need to remember. Okay, next, this is about some introduction and some criteria. I'll explain a little bit about some epidemiological points. Okay, epidemiology. What you need to know is, DSM-5 cites that 5% of school age children have ADHD. 5% of school age children have ADHD. Okay, and what it says is, in the elementary school age, the boy to girl ratio is 9:1. Okay, boy to girl ratio is 9:1 in elementary school age. All right, this is one thing. And another thing you need to know is, girls are more likely to have predominantly inattentive presentation. Predominantly inattentive presentation is more likely in girls. Okay, that you need to know compared to the boys. Okay, and Yeah, that's it. And apart from this, you need to know something about some comorbidities. Okay, ADHD is found to be very much comorbid with ODD and conduct CD, that is oppositional defiant disorder and conduct disorder. Okay, comorbidities present. As many as 50% children will have this. 50% children with ADHD will have a comorbid ODD or conduct disorder. Alright, and in adolescents, if you see, you may notice that they may have some substance abuse. Okay, in adolescents, what you need to remember is substance abuse. Alright, this was a little about etiology and comorbidities. Next, coming to etiological factors. Okay, now for the sake of easy learning, I divide the etiological factors into genetic and non-genetic causes. Okay, in genetic, we have certain syndromes which may be related to this, like Fragile X, okay, Fragile X, G6PD deficiency, okay, generalized resistance to thyroid hormone, phenylketonuria. All these are genetic syndromes or diseases which are related with attention deficit hyperactivity disorder. In non-genetic causes, I divide into prenatal, perinatal and postnatal. Okay, in prenatal causes, you have a young mother, poor maternal health and maternal use of cigarette or alcohol. Cigarette or alcohol in the mother use is going to be related to prenatal factor related to non-genetic cause of ADHD. Okay, next, in perinatal causes, you need to know if premature baby or preterm baby, okay, is a risk factor, and IUGR, intrauterine growth restriction. These are perinatal factors. Postnatal factors, infantile malnutrition, okay, infantile malnutrition, lead exposure, lead toxicity, lead exposure, okay, any brain trauma or brain injury, okay, and brain infections also. Certain brain infections may have a long-term side effect or long-term outcome of ADHD. Okay, now this was about the factors as such. Okay, now I'll add some more points in the etiology side. Okay, so what I'm going to mention is that there is a social stigma that some certain child rearing practices in the mother in the deficit, like, you know, society wants to speak about the psychological issues and psychiatric issues. They just say, yeah, the mother didn't raise the child well, okay, that's why the child doesn't listen to the mother, okay, he's always, like, you know, not listening to anyone, he's just running around doing all this kind of stuff. So what you need to know is studies have proven that child rearing practices, okay, do not cause ADHD. Okay, this is important. Next, so neurobiologically, a common feature was found that there is relative immaturity of prefrontal cortex in these children. Relative immaturity of prefrontal cortex, which obviously is important for executive functions such as planning, organization, working memory, sense of time and impulse control. Okay, and ADHD children have thus less tolerance for delay, okay, and different response to reward than a developmentally normal child. Normal typical development child will have a different response to reward system and he will have a different response. Okay, now what you need to know, neurobiological is over. Neurochemically, what is the neurotransmitter systems which are involved in ADHD: norepinephrine, dopamine and serotonin. All right, ठीक है. Now what you need to know: genetics I have mentioned, and let's talk little about some soft signs. Soft signs are nothing but non-localizing neurological soft signs. These are okay. Non-localizing neurological soft signs in ADHD are clumsiness in a child, okay, left right confusion, okay, perceptual motor discoordination, dysgraphia, okay. All these can be soft signs for ADHD, okay. Now, but the thing is, the presence or absence of soft signs is not a diagnostic criteria, because we have not mentioned these in diagnostic criteria, right? So there is a reason, but this may help in targeting symptoms for treatment. Like, you need to see that if these are there, we need to definitely get the child out of these symptoms. All right. Next, a little about the course and prognosis of ADHD. Okay. Now, what you need to know in course and prognosis of ADHD is mothers, like how does a typical case present? You know, the mothers will tell some history of related definitely to hyperactivity, impulsivity, and attentiveness. But what they will tell also is, like, you know, some mothers may even report something like excessive intrauterine kicking, okay, or they'll tell something like, you know, when he began to walk, he also ran. Okay, so basically the child could not, you know, wait for, you know, just to learn walking and perfect himself in walking, but he even started running. Okay, and if the preschoolers and all this age is the onset, definitely this will come out openly very easily, because, you know, in preschoolers and this age, and especially with oppositional defiant behavior, they may be expelled from daycare or preschool, and mothers may be, like, you know, worried and all this. So this may be definitely one problem. Okay, but if it's less severe, the disease is less severe, it may take a lot of time to get diagnosed, because, you know, you can't really pick up an inattentive child if the severity is very less, right? And and you know, sometimes what happens, you may pick up such children of ADHD very late in their school age. Why? Because with increasing grade of school, the norms, the discipline norms increase, right? Sitting still, not talking, okay, giving a prolonged attention to a class, social norms following, all these are, you know, are more you know, demanding at an increased school grade age. Okay, so definitely at that age some students may be clinically evident. All right. Now that is basically greater academic demand for organization and concentrated effort, that is middle school, high school. Some children may even be apparent in college or graduate school also. All right. Now, are there any secondary effects due to this ADHD? Yes, definitely there are secondary effects. Secondary effects involve low self-esteem in the child, low self-esteem, and significantly compromised social skills. Social skills are compromised. Okay, so these are secondary effects. Now, this youth of ADHD is more prone for dropping out of school, okay, or college, do not graduate. They may have more increased car accidents, okay, increased court appearances, juvenile court appearances, okay, and increased suicide attempts, okay, because of comorbidity and all that. Okay, early sexual activity, all right, and problems in relationships. Okay, and I have already told about substance abuse and delinquency and all that, right? So yeah, that is also you know, some of the problems which you may see. Now, what you need to see is there are some good prognosis, bad prognosis markers for ADHD. Okay, so what are we going to do for that? I'm going to tell you just 2-3 points. Okay, so the absence of significant conduct problems or defiant problems, aggressive behavior, and presence of a good IQ are good prognosis. So for good prognosis, bad prognosis. For good prognosis, absent defiant behavior, or no aggressive behavior, okay, and high IQ are good prognosis factors. Okay, what about poor prognosis? Okay, more severe and prolonged symptoms of ADHD, comorbidities in the child. Okay, comorbidities as we have discussed, parental mental health problems, okay, and like I told, a prolonged duration with ADHD, prolonged symptoms with ADHD may be associated with worse prognosis. Okay, the risk of early death is also increased in ADHD children, like I told, because of suicide, homicide, or accidental death. All right. Now, what we have noticed, what the people have noticed, in the mothers of the children with ADHD, they are tend to be more controlling, more directive, more structure setting, and more negative responsive to the children. Okay, that is one thing which was found. And you have found that many parent-child conflict incidents or parent-child conflict episodes will be there in ADHD children. They'll be relating to that. Sometimes you may even notice that mother and father themselves may have some comorbid ADHD and all that, because genetic factors are also there, right? So you may find sometimes that the mother or father may also be having ADHD. Okay, now coming to evaluation, this is about the course and prognosis, a little about course and prognosis. And coming to evaluation of a child, what you need to know is there are diagnostic. First, I'll mention the chart criteria and checklist: diagnostic and prognostic. Okay, there are some diagnostic checklists. Okay, diagnostic checklists for what? ADHD. There are CBCL. Number one is CBCL, that is Child Behavior Checklist. Second one, TRF, that is Teacher Report Form, which teacher will be filling. Okay, then CSI, Child Symptom Inventory. Then there is something called Vanderbilt ADHD Scale. There is something called SNAP 4 scale. Okay, and there is an ADHD, last but not the least, ADHD rating scale 5. Okay, all these are for diagnostic purposes. Okay, what you need to know for prognostic purposes, that is for monitoring the treatment. There are some scales. The first one which you need to know is CAP. Okay, that is Child Attention Problems Rating Scale. Number 2, Iowa Connors Teacher Rating Scale. Okay, and last one is CPT, that is Continuous Performance Test. So this is something which you need to remember and memorize. Nothing to do for this. So this I wanted to mention and get away with. So diagnostic checklists and prognostic checklists to the treatment. Okay, next thing what you need to know in evaluation, what I want to mention is, obviously for evaluation definitely you will apply the criteria and everything, that is done. But what you need to know is, rather than the clinician's own room, the clinician's waiting area may provide a more realistic sample of the behavior of the child, especially if it's a mild ADHD. All right, milder form of ADHD, the child may become somewhat conscious and not do be himself in the doctor's room. So in the waiting room, someone may notice like, yeah, someone may notice what is the problem actually. And what is very important about ADHD children is parent interview. The parent interview is crucial for diagnosis as well as comprehensive assessment of the child with ADHD. Okay, in this parent interview you will be even taking obstetrical history such maternal substance abuse, perinatal prenatal injury, medical history in mother like hypothyroidism, or mother has any mental health disorder or tics or any medication use, screening questions for sleeping disorders, okay, any family led exposure, family residence, okay, anything like that, and family psychiatric history, family medical history, okay, or any abuse, okay, by child, medication abuse in child, siblings or parents. So all these things you may be asking to the mother, okay, parent interview. This is a quite important thing which you need to mention if this topic is there, okay. And what you need to know is in physical examination, what will you be doing for the child? We'll be looking for any other physical anomalies in the child, thyroid, any evidence of thyroid disorder, any chronic illnesses, okay. You need to check for height, weight, anthropometry of the child, okay, and tics, any tics if present in the child, cardiac status, because you have to do treatment and everything, right? So some may have some side effects to the heart and everything, so you may need to see that also. And neurological examination, that is a proper like evaluation of the neurological system, that is like doing a scanning or doing an EEG. EEG or brain scanning is indicated if only there is focal neurological signs or any clinical suggestions of seizure disorder or a decline of cognitive functioning of the child. Alright. Laboratory wise, you may need to check for the thyroid function or blood lead level, okay. And even in examination, visual acuity, hearing needs to be tested before you label the child as ADHD, okay. And a prior ECG is not indicated always, okay, unless there is a patient history or family history of cardiac disease, okay, before starting any treatment. But as such, without all this also, ADHD is a clinical diagnosis and it is based on interviews, standardized parent teacher behavior rating scales which I have mentioned. Alright, that is what you need to know about this evaluation part of ADHD. Okay, next what I want to mention is some differential diagnoses, just some listing of some differential diagnosis. What you need to know is a normal high activity level is also there, okay, which may represent a form of adjustment disorder, number one. Number two, some physical problems like sleep disorders, nutritional problems and all this, so these may appear to be as ADHD, okay. Then I told you about thyroid disorder, right? Hypo or hyperthyroidism, okay. And then situational anxiety, PTSD, boredom in school, okay, neglect or child abuse, all these may also appear to be as ADHD. Then I also told you about conduct disorder and oppositional defiant disorder, okay. Some youth with depression and anxiety can present with deficits in attention, okay. So depression and anxiety also you need to mention, okay. Then and there is something called as new DSM-5 diagnosis called disruptive mood dysregulation disorder, or DMDD, okay. It is characterized by chronic irritability, reactive aggression, severe mood lability, and this is very much confused with ADHD by many experts also, so not a big problem, but yeah, you need to remember that as a. And psychosis you have to rule out, because stimulant treatment can actually make it worse, okay, because you need to go for stimulant treatment in ADHD, so we need to definitely rule out psychosis in the child, okay. And definitely other things you have to rule out is intellectual disability, autism spectrum disorder, okay. All these things you need to mention. All right, undiagnosed intellectual disability or learning disorder may also come out as this, okay. Next what we'll discuss is about treatment, okay, which is hopefully the last part. Yes, it is the last part. Treatment. Treatment wise, I'll be just be talking because I don't want to write down, but what you need to know is the headings. In headings, first we will be writing in treatment is about parent education. Parent education. Number 2, school related interventions. School related interventions. Okay. Number 3 is pharmacotherapy. Pharmacotherapy. And number 4 is psychotherapeutic interventions. Psychotherapeutic interventions. And something, some unestablished treatments are also there, and that I won't mention much, but dietary treatment I'll mention, okay, because it's mentioned in the book. Now coming first to parent education, what you need to educate, you need to educate the parent regarding the nature of the disorder first, and the management is the key, and its management is the key to treatment of ADHD, okay. And what you need to know is parents should be coached about how to best work with the school to meet their child's needs, okay. Parents are advised to establish specific spaces for homework, closely monitor the peer activities of the child, and tailor the activity to the child, to the individual child's strength and weaknesses. Alright. Related to school related interventions, the parent should inform the school about the child's strengths and the child's vulnerabilities. Okay. An individualized education program, or IEP, individualized education program called as IEP, can be developed with the school to ensure that the child receives the needed services. Okay. What you need to know also is a notebook, giving a notebook for documenting assignments and completion of homework that is carried daily by the child between the teacher and the parent can be an effective modality. Okay. A daily report card system, okay, which targets specific behaviors, can be completed by the teacher, and the consequences will be provided by the parent. Environmental modifications, what you can do, environmental modifications in the school, closely supervise recess, that is a break time, okay, and closely supervise physical education, and bus cafeteria arrangements, all these things should be done. Now one more term which was given by Fifner in 2016 is collaborative life skills. I'll write this down. Collaborative life skills. Collaborative life skill is an empirically supported treatment model. Okay. It combines many behavioral interventions which is implemented by the school staff, like between parents, teacher and primary school students in children with ADHD. And this improves behavioral and academic functioning of the child. Okay. So all these things you can do at school level. Next, coming to pharmacotherapy, what you need to know is medication is the primary treatment for the core symptoms of ADHD. Okay, medications. Now what are the medications you go for? The first line treatment is this, I'll write down. The first line treatment is stimulant therapy. The first line treatment is stimulant therapy. In stimulant therapy, you have methylphenidate, and amphetamine, which is now less commonly used. Amphetamine. If this doesn't work, you go for atomoxetine. Atomoxetine, which is a norepinephrine reuptake inhibitor. It has an FDA indication for ADHD. And if this does not work, atomoxetine, we will go for guaifenesin or clonidine. Guaifenesin or clonidine, okay, which are alpha 2 adrenergic agonists. Okay. And the last is bupropion. Bupropion is an antidepressant actually, and you can add it if nothing else, it's not responding to anything else. Okay. But what you need to know is if there is aggression in the child, you may add atypical antipsychotics, and if depression or anxiety, you may add an SSRI. Alright. Okay, now how does this stimulant therapy work? A small note on that. How this stimulant therapy is working. Okay, this stimulant therapy works by the goal of amplifying tonic but not phasic norepinephrine and dopamine actions. Okay, so tonic actions are amplified and phasic actions are not amplified of norepinephrine and dopamine, and therefore they control the rate of stimulant drug delivery, the degree of transporter occupancy, and the duration of the transporter occupancy of these neurotransmitters. Thereby, there is a graded stimulation of the child, not just phasic, tonic and phasic both. Tonically, the child will be stimulated like a normal child. Okay, that is one thing. So we are done about the pharmacological interventions. Let's discuss a little about psychotherapeutic interventions, where punishment and contingent rewards are required and consistent, intensive, prolonged treatment may be needed psychotherapeutically. Okay, so what is the things you can follow? Time out and response. Okay, and response cost. So time out you can do and response cost you can do. Time out, you know. Response cost is removal of points, rewards or privileges if there is misbehavior or any specific behavior modification needs to be done which the child is not doing. Okay, and then definitely you can follow cognitive behavioral therapy. Cognitive behavioral therapy will help children learn the social and the academic problem solving strategies. They'll help them to monitor their own performance, remind themselves of their rules, praise themselves for their accomplishments, and this is very much effective in children with ADHD, not just to reduce the ADHD symptoms, but to help the child to cope with his disease and become functionally better. Okay, this is what you need to know about the cognitive behavioral therapy, which comes under psychotherapy. Okay, next, coming to last, that is dietary treatment. In dietary treatment, you can say कि supplementation of polyunsaturated fatty acids, omega-3 fatty acids of fish oil, okay, has been found to be useful, and melatonin may be helpful in reducing initial insomnia in children with ADHD, but it does not help for the core symptoms of ADHD. Okay, and there is something called as Feingold diet. Feingold diet, which is interesting when I read about it, but just mention of it is enough. Feingold diet. Okay, it omits actually both natural and artificial salicylates and food dyes, but its usefulness has not been proven as such. Okay, and unestablished treatments may, a very famous one is caffeine, which many say it's a natural treatment for hyperactivity, but it's still not proven to be efficacy, and we don't know about the significant we know that significant side effects are there of caffeine. So yeah, this completes the topic of ADHD. I'm sorry if I was out of vibe today. So basically what I have discussed today is some points about introduction about ADHD, the criteria, the epidemiology, some points about comorbidities, etiological factors we have discussed, and some extra points related to etiology and course and prognosis, good prognostic factors and bad prognostic factors. In evaluation, we have discussed about checklists, which is both diagnostic checklists and prognostic checklists, prognosis to treatment, along with some differential diagnosis. And treatment, we have parental education, school related interventions, pharmacotherapy, psychotherapeutics, and dietary treatment. And I've mentioned a little about the stimulant therapy, atomoxetin, guaifenesin, clonidine, and bupropion. This is the order in which we'll go for the treatment. Okay, this is number 1, number 2, number 3, number 4. Okay, and that's it. And Feingold diet. So thank you so much for listening to this class. I'm sorry if I was out of zone today, but definitely ADHD is an important exam topic, child psychiatry wise, for pediatric postgraduates. And the source of this was American Psychiatry Association. Okay, American Psychiatry Association, that is DSM-5 edition of Child and Adolescent Psychiatry. Okay, so yeah, publications I want to mention once. The publishers are American Psychiatric Association Publishing. Okay, so it's American Psychiatric Association DSM-5. And again, signing out. I don't know which class I'll be taking next. Probably I'll be taking towards a more systemic topic. I'm Dr. Waheed Hussain. Okay, please like and subscribe and spread this videos to someone for whom this may be useful. Okay, and thank you so much. Yeah, see you next time.